Dr. Ayal Willner. He is special to me because he trained me in my first rotations in residency. Dr. Ayal Willner is a board certified. Let me get rid of our overlay here and greet you. Hello.
Hello.
I'm going to give a very brief summary of your background and then ask if you want to add anything at all. Dr. Ayal Willner is a board-certified otolaryngologist. He graduated from Cornell University before earning his medical degree at Albert Einstein College of Medicine. Dr. Willner has extensive training in head and neck surgery and was an assistant professor of otolaryngology and pediatrics at George Washington University. Dr. Willner is an active member of numerous organizations, which are listed in his impressive biography at SoCalEarNoseandThroat.com. In an exceptional way, he actually has traveled and volunteered his surgical skills with a program called Mending Kids to provide free surgical care for children who cannot afford it all over the world. Dr. Willner, is there anything I missed that you would like to add before we begin?
The only thing that I would add, because this is a talk for parents of children, about children, is that I did do, and maybe I just missed this, I did my pediatric ENT fellowship at Willner Children's Hospital in Memphis, Tennessee. And then while I was in Washington, D.C., I was at the Children's National Medical Center for those 2 years. So I've been taking care of kids for 30 years or more. Hate to say that.
Yeah, I know, right? It goes fast.
And one last thing is that Dr. Vivi was an amazing resident. And so it is not at all surprising that she has become an amazing pediatrician.
Thank you. It's very neat to be full circle here and being able to share what you've shared with me, with the public. So we're going to start with one of the most common reasons that people show up in the pediatric office, pediatric ear infections. We want to know what causes them and how can they be prevented?
So in order to kind of understand the ear infections, one has to understand sort of like why we have the space behind the eardrum called the middle ear. And the bottom line is fish that get their sound, their vibrations from water going into their inner ear, which is filled with fluid, there's no loss of energy. But because we speak in air and we have fluid inside our inner ear, and we will lose energy. The inner ear is where that vibrational energy of sound gets changed into electrical impulses that the nerves pass along to the brain. And so behind the eardrum, there are the 3 ear bones that many people have heard: the hammer, the anvil, and the stirrup. And the whole purpose of those ear bones in the eardrum is to transmit sound and directly vibrate the fluid inside the inner ear. So why is that important? The importance is that on both sides of the eardrum, there has to be air for the eardrum to vibrate normally. Because it's filled with fluid, we're back to the situation before we had the middle ear. So that's why it's there, and it's the way the air gets there is from the auditory tube, which you can see in the lower right-hand corner of that graphic in red. Air comes that ends in the back of the nose, and then it goes up to the green area, which is the area behind the eardrum, the middle ear space. That's very important for us to be able to keep air behind the eardrum. And when that doesn't work, we end up getting fluid. In kids, the angle of that tube is much flatter. The opening, the lumen of the tube is much smaller. The tube is much floppier because that tube is normally kind of a rigid cartilage that opens and closes and opens and closes. It's shaped kind of like a candy cane if you were to cut through it, and where the top end of the candy cane kind of separates and comes closer and separates and comes closer to allow air in, because normally the eustachian tube, the auditory tube, is closed. So when the auditory tube isn't functioning, you don't get air going up. And the other thing that it allows is for fluid to go down. Why is there normally fluid there? Because anytime you have an outpouching from the tube that goes from our mouth out the other end, anytime you have an outpouching, bacteria would like to crawl up that outpouching, and then so we have little hair cells and little bits of fluid to clean everything out. That's why if we have something in our lungs have little hair cells to clean things out. And when fluid that's supposed to travel and get cleaned out doesn't, it gets infected. That would be your gallbladder, your urinary bladder, your sinuses, and the space behind your ears. Mm-hmm. So the auditory tube has multiple factors that may not work as well in a kid. As I said, they're more horizontal. They are more, the tube is floppier. The tube is shorter, so the bacteria have less room from the back of the nose, or less distance from the back of the nose to the middle ear space to travel. So when the eustachian tube isn't working, or the cilia, the little hair cells aren't working, or the immune system isn't working as well, all those things can lead to a situation where fluid gets built up, and if it doesn't get clear, it will get infected. So and what are the things other things that can happen? Well, if there's swelling around the opening of the auditory tube, well, it won't open as well. Swelling, yeah, like a cold. That's why ear infections are so often related to a child having a cold, because they don't work as well to begin with, and a cold can lead to congestion. So what are the things we can do to have it not happen? Well, one of the main things we can do is decrease the congestion. Now, that doesn't mean that we can make it so that children don't get a cold ever, although I think with the pandemic, we tried a little experiment of sequestering all children, and I think they probably had less colds. And I certainly put in less tubes because of it. So it did work, but obviously there were a lot of other negative effects of it. So I'm glad that we're getting out of it. But when a child has a cold, using a decongestant, even using saline spray like Little Noses or whatever CVS brand, just any kind of saline spray to squirt up the nose and help clear those thick secretions so they don't plug up that already swollen eustachian tube or auditory tube opening, will better allow fluid to not get built up. Another thing is not feeding a baby with a bottle on the back, because this is at the back of the nose, and if some milk is hanging out there because the baby's feeding from a bottle on his or her back, that can lead to some swelling and irritation. And not only is it good for babies, but bacteria like it as well. So it can help them thrive. Also, by keeping a baby propped up when they eat, first of all, it's a more efficient way to get food into where it needs to go. And second of all, every time they swallow, they activate that auditory tube. In fact, when you swallow, the auditory tube opens, and then when you release the swallow, it closes back down. And that opening and closing will help keep that fluid, that is the small amount of fluid that's produced to clean out the space behind the drum. It'll keep it flowing down into the back of the nose. So by keeping a baby propped up, we let gravity help us get that fluid out. By not having a baby lying down for a bottle, same thing. By keeping the congestion down, and that depends. In younger kids, have more ear infections. The peak incidence of ear infections is at age 2, and then it kind of decreases until about age 4 or 5, and then there's a little bit of a little hump in terms of if you looked at it in a graph, where you a little bit less decrease or a little bit of an increase in the incidence, and then it goes down by age 6. And that's probably because at age 2, kids are being more social, more interactive, putting their finger in their mouth and then on more toys. And then at age 5 or 6 is when kids go into school. And so they're exposed to new bacteria. So the best thing you can do is treat a cold symptomatically, to keep things open, try and keep the congestion down. Don't bottle feed, and let gravity help.
A couple questions regarding children and ear infections. The first one is, we see a familial tendency to have ear infections. What is that link? What's going on? Is it an anatomic genetic factor when we see 3 children in a family needing tubes?
Yes, it's both an anatomic and a physiologic factor. Those 3 kids in the family probably look more close to each other than they do to 3 other kids from a completely different family. So they may have the same angulation of the auditory tube. They may have the same short distance of the auditory tube. And then there's the how fast do those little hair cells go? How thick is a little bit of fluid that is produced to help rinse down the bacteria? How thick is that? How well, that's called the mucociliary blanket. And how well does that, how efficient is that system at cleaning out the bacteria? And so if you're starting with the same genetic, predispositions, it's not surprising that you get those kinds of things. One other thing that I forgot to mention in slightly older kids is allergies. Allergies leading to congestion not only of the nose, but that same lining of the nose is the lining of the auditory tube. So if you have allergies and you've got a lot of congestion, that can further make the auditory tube function decrease and increase the likelihood of an ear infection. So again, if you have 3 kids in the same family and mom and dad are both allergic, and all the kids are doing the allergic salute, which is this, then they're more likely to get ear infections.
And to clarify for the audience, we're calling a middle ear infection right now. This isn't swimmer's ear where water gets stuck in the outer canal, but we're just talking
Correct.
About the mucus.
If you look at there's 3 quote unquote ears. There's the outer ear, which is the purple area, also called the ear canal. When that gets infected, that's swimmer's ear. The green part on the other side of the eardrum, or tympanic membrane as it's labeled here, is the middle ear space. It's the space where the hammer, anvil, and the stirrup live, and it is what is responsible for fixing that problem of sound traveling in air going into a fluid-filled organ of hearing called the cochlea. And the cochlea and the semicircular canal here, those together, that area is called the inner ear. And it's very, very rare to get an inner ear infection. We don't really need to discuss it. It's a serious thing, but that's really, really, really rare. Most commonly is the middle ear infection, or it's in medical terms otitis media. And that, again, is because you've got that airspace that's not getting ventilated. It's not getting air up it the way it should be. And it's not getting the little bit of fluid that's produced to rinse out the bacteria. That's not getting out. And that's most commonly due to problems with the auditory tube, although it can have to do with problems with the little hair cells, or problems even with not problems, but aspects of the immune system. So babies don't have as developed an immune system as adults, so they're more susceptible to getting infections.
As a clinician, and I see children with recurrent ear infections, I do often see enlarged tonsils, which may mean enlarged adenoids. Do you often see them connected?
Yes, adenoids, there are a couple of reasons why kids, for instance, need tubes for chronic fluid behind the ear or recurrent infections. When a kid is in the 1 to 2 year old or 2.5 to 3 year old even age, it's most likely due to the auditory tube and that kind of thing. When it happens at a little bit older, like age 4 or 5, when parents come in and say, my child has had 5 infections in the last 6 months, what's going on? He never had problems as a younger child. That's when you want to think about allergies and adenoids. So allergies don't usually start out at such a young age, but by 4 or 5, kids can often have them. And that can be what is now leading to ear infections in a kid who didn't really have the problems before. When with big tonsils, when you look in and see big tonsils, most oftenly they're also enlarged adenoids. And the adenoids can actually act as a physical plug of the eustachian tube, of the auditory tube, and B, as a reservoir for bacteria. So at times, if a child is, for instance, a mouth breather, and I look in the nose and it's not congested, I can look all the way down. Everything it's not a lot of mucus. They don't have a cold. They don't look the lining doesn't look pale pink or purple like it does in a child with allergies. Then I start to think of, well, are the adenoids enlarged? Because they could, as I said, physically be blocking the back of the nose, which is why the child is a mouth breather, as well as blocking the auditory tube and leading now to those to the recurrent infections or fluid.
Okay, I'm trying to fit this in my notes. That was a great explanation, really useful for clinicians who do tend to tune in and watch. And then two more questions on this topic, and I think it's worth spending our time on because that is what in every pediatrician's day, it's somebody's coming in the office for ear infections, minus this last year of the pandemic, really a drop in colds. We're seeing so much rhinovirus right now, though.
Yeah.
So I'm not shy to do Benadryl with patients who have allergies in the family or a family history of recurrent ear infections. Zyrtec, of course, there are some other options. Is there any age that you say is too young? Zyrtec, the allergists tend to give at very young ages. Benadryl, I'll start close to 1 if needed. Not necessarily to treat. Benadryl is acceptable for certain scenarios, but do you have a preferred decongestant at in infancy to toddler years?
Well, Benadryl is more for allergies. It's an antihistamine. It can sometimes sedate. I like saline, and then in a slightly older child, I'll use something like and it is a brand name. I'm not working for the company, but it's Flonase Sensimist. And it is a steroid, and while it is a steroid, it gets broken down immediately once it gets into the system. So it is really only locally prevalent and does not build up in the bloodstream. So all those things you worry about in terms of steroid, for a short course of a week or two around a cold, it may be able to help. And the thing about Flonase Sensimist is that it's a very small volume and a very fine mist. So when the kids don't want to let you spray something in their nose, you can often do it while they're asleep, and they won't wake up because it's really difficult to feel that it's actually working. So that's something else that can be done, and that will work in a cold situation where the swelling is not mediated by histamine, and so it may be worthwhile to do something that works in a different way. The other thing in older kids, you can use, there's Afrin Junior. Now, Afrin, I'm going to state, is an important adjunct, but it is something that you want to use very sparingly. So if your child has a history of ear infections and gets them with every cold, and they've really got a bad cold, then in a 5, 6, 7-year-old, a little squirt of Afrin Junior, 1 squirt each side, twice a day for like no more than 2 days, is probably something that can help keep the nose open, and then once the big hump of the worst part of the cold is over, then you go back to just using saline. And that doesn't mean that while using the Afrin you stop the saline. Just a little saline spray can go a long way.
Yeah, we do love saline. There's so many ways to give the saline. Adults, there was a study that using the spray bottles, some people would report increased sinus infections, but the children do have much more open sinus cavities, correct? It's not a concern to be spraying something inside the nose with
Yeah,
any force.
I mean, you don't you don't want to spray things with too much force anyway, and there's no need to. It's that's why I say that, like the ocean nasal sprays, the atomized sprays, as opposed to the neti pot style stream sprayers. The older kids, 5, 6, 7, 8, and older, you can use those squeeze bottles, like Sinus Rinse is one that's out on the market. The
That is the stream, though. That's what I
That's the
think.
stream. So for those older kids, you could use that, but there's no real reason to give a real good, real strong squeeze in any of these situations. A good gentle squeeze, just a gentle squeeze is fine, and will get where it needs to be. The nose is not that big, especially in the younger kids, that you need to get this spray a foot away from the nozzle. It's only got to go, an inch and a half, and it's going to get everything that you need to do. So gentle is better for lots of reasons, including you don't want to cause irritation, and you definitely don't want to do something that's gonna give any kind of pain, because then the next time you want to try to use it, it's going to be a lot more difficult, and it's just unnecessary. A nice gentle is the way to go. And with the atomizer, the same thing. Just a nice gentle squeeze will get the spray where it needs to be, and no need ever for really a strong squirt, unless a child is in very specific situations like post-op sinus surgery.
And when you say an atomizer, you're talking about the cans that look almost like a whipped cream bottle?
No. I'm talking about just like with like little noses or air spray. When you squeeze it, you get a fine mist. You don't get a stream. So
Okay.
ocean nasal spray, little noses, air. Every CVS, every Walgreens, everything has their own brand. It's just saline spray, but it's a mist, and that's what for the little kids you want a mist. For the older kids, you can use a little bit of a stream, and again, those come in all sorts of flavors, all sorts of brands and types. The ones that you ones that you squeeze the bottle, ones that are pressurized, but you don't need a lot of pressure. To do what you need to do, which is basically help the body a little bit. Our bodies live, and we are beings such that a little bit of help can go a very long way, and radical stuff is rarely needed.
This is so valuable. It comes up in all my newborns, and I actually get to take time to show them how to spray in the nose and how to suction. But I do caution the parents, the direction that they're suctioning is so important, because if they're getting mucosa, they cause quite a bit of swelling, and then they do the opposite of what they're trying to do. And I see that nose is red and swollen because they're on the skin. So you really want to get in the airway. And going to your point, we see so much improvement with just the mist alone, and less something non-invasive in a baby. I don't really love parents going in the nose too much, but getting that mist in there, they will either move it backwards or sneeze it out, or you can go in with the end of a Q-tip. When you pull out the cotton, it will catch some of those boogers, and you can pull it right out. So the mist is so underutilized, and it's something I do talk to all my patients about. There are some with xylitol that they brag to be anti-infective. Do you believe that?
I mean, there are some anti-infective. It makes it a little bit more inhospitable for bacteria. There are interesting studies that we actually have taste receptors in our nose. And what those taste receptors actually do is they sense bacteria. And there are
Oh.
specific taste receptors for specific bacteria or groups of bacteria. And when they get activated, they make those hair cells go a little bit faster. And they make something called nitric oxide, which bacteria don't like. The body makes more of that nitric oxide. So the body has these mechanisms, and we don't want to disturb those mechanisms. But a little bit of saline spray along with those will help clear things out and allow the body to do what it does naturally.
And have you seen the nose Frida and the Nespira? Have you seen people use those?
Yes,
approve of
that's fine. You need to be careful. A congested nose in a kid with a cold is already inflamed. And
Right.
so if you are suctioning real hard with the nose Frida or anything else, you're likely to suck on the mucosa and then cause tissue trauma. And if you see some bleeding, that's not anything necessarily to be panicked about, but it is something to take note and to say, I might be suctioning a little bit too hard. Let's use a little bit of saline, a little bit more gentle suctioning, because again, the goal here is not to clear out everything all the time and have a baby with a cold never have any mucus, never have any boogers, never have any congestion. That's part and parcel with a cold. We want the baby to be able to sleep at night. We want the baby to not get ear infections. We want the baby to be comfortable. And that's kind of where I would say using those suction devices are helpful. But again, just gently.
Yeah, so at the start of this conversation, you made a very simple and true point. That is what this is all about, is that at the base of the eustachian tube, if it's getting clogged and backed up, you don't want to dry clog there. You want to give it a little bit more fluid to help move it out.
Yep.
And that first day or two of rhinovirus, when they are just streaming wet, I find parents suction. I'm like, it's just going to keep coming. You don't need to move that wet fluid. It's like a waterfall, right? It's just going to keep coming, and it's moving. It's not causing problems. It's, day 3, 4, 5, when it's thick yellow, green, and it's going to be causing that blockage that you mentioned.
Right. And that thick yellow green doesn't mean that, something terrible has happened or that it's necessarily bacterial, because viral infections will also lead to thick yellow green. It's really a question of, you want that to clear in a couple of days, and you don't want that to sit around, because if it sits around, then there's a higher risk of bacteria gaining a foothold. And so in those situations, that's where you use the saline and a little bit of suctioning if necessary, a little bit of decongestion to try and open things up so that it doesn't sit there, as you mentioned.
Okay, great. Such high yield information. I really appreciate it. We're going to go on to the second very high yield pediatric. Basically, you do a lot of the bread and butter when it gets too tough for us to handle. So the next question is, when do you need to worry about strep throat?
Hopefully you don't need to worry about it. You do need to treat it. Strep throat is a bacterial infection that is very, thankfully, still very sensitive to many different antibiotics. Strep throat is technically a infection of the tonsils caused by group A beta hemolytic streptococci. There are many other bacteria, fungi, viruses that can lead to an infection of the tonsils. We call it strep throat because back when all we could test was for the strep bacteria, it became known as strep throat. So when you need the one thing about the strep throat is that it can lead on rare occasion, and did before the advent of antibiotics. It led to heart problems like rheumatic heart disease, acute rheumatic fever, as well as kidney problems. So it's not something to worry about but it's not something to ignore either. It is a real infection, and especially in younger kids, you don't know how the body's going to react. There are plenty of kids who will, in fact, get better on their own without an antibiotic, but there is a small risk of one of these other things happening. And if I find like a child has had a red rash with their strep throat, a scarletiniform rash, then it's telling me that we're already getting systemic reactions to the strep. And in that kind of a situation, it becomes more imperative to treat these early. And I guess when you need to not worry, but bring it to the attention of your pediatrician, is if you go to your pediatrician and you're treated with antibiotics and you start the antibiotics and things aren't getting better. If they're not getting better, you need to follow up and see if other things that can develop might be developing. For instance, one can develop an abscess, which is a collection of pus between the tonsil and the side wall. It's called a peritonsillar abscess. If a child is having difficulty swallowing, drooling, their voice is a little muffled, it's called a hot potato voice, as when you put a piece of hot potato in your mouth and you don't really want to move anything. When that kind of thing happens, often with fever, then the initial antibiotics may not be working, and a follow-up visit to Dr. Vivi it may be in order. So that's when you need to be a little bit more concerned, and that's when you need to get further follow-up.
I originally wrote the question for discussing when would they come see you, how many strep throat infections means that there's something anatomical that needs to be evaluated by you. So is it 3 in 3 months? Is it 5 over 2 years? What do you like?
I will give you the official answer, and then I'll give you a more realistic answer. The official answer by the American Academy of Otolaryngology Head and Neck Surgery is that tonsillectomy should be performed if a child has 7 infections in 1 year, 5 in each of 2 years, or 3 in each of 3 years. Now that's a guideline, and really needs to be viewed as such, because 7 infections for an 11th grader can really have a detrimental effect on their life and on their education, their ability to participate in sports. And 10 infections over 2 years, again, that can really knock your ability to excel academically by a lot. It kind of depends on how bad is the infection, how bad does it put the child out. If you have 5 infections in 1 year, then you should probably come see me. But if you come in and you say, yeah, he gets an infection, fever's not too high, we get some antibiotics, it clears really quickly, then I might say, well, 5 is it's not quite 7, let's watch it. It also depends if you say, well, he had 5, they all started in February, and we kind of treated him, or in January, and treated him for 3 months, 5 times in March, but he hasn't had anything since, and it's now May. Then yeah, 5 times is a lot, but the question is, was that just a bad winter? Or are these tonsils so inflamed, and have they gotten to the point where they're just going to keep getting inflamed that they need to come out? So, the tonsils, when they get infected and get swollen, they don't clear debris out of the crypts. So the tonsil has like between 10 and 20 little crypts or caves in them. You can see the openings when you look at the tonsils. And oftentimes you'll see white spots in those openings when they have a throat infection, and that's pus kind of coming out of those little squiggly caves. And it sometimes gets to the point where no matter what you do, you're really not going to be able to clear the depth of the cave. Studies have shown that that when you clear the surface of the tonsil with antibiotics, oftentimes you have not cleared the core of the tonsil. And they've shown that in tonsillectomy specimens that there is like a 100 to 1 fold increase in the amount of bacteria deep in the crypt than on the surface. So a surface culture that's negative doesn't mean that there's nothing going on. So if there's a question, then you should come see and go see an otolaryngologist to take a look at a careful history, see what the tonsils look like, find out how badly the child is affected by these infections. If it's having a very big detriment to the child's life, then I kind of will look at it and use the guidelines as guidelines and say, okay, but we're in an untenable situation with a kid getting sick every time whatever happens, and we need to act on this.
This is great information for parents because they'll hop between urgent cares and their pediatrician, and the pediatrician won't have a complete log. I like to keep track, and will often make just a chart note of how many a child has had. The other scenario that I would love your expertise on is I can treat abscess. I can treat, sometimes I know what to do. I know what's coming, and I can treat it with, some heavy duty antibiotics. Do you want to see any patient after they've had a tonsillar abscess? Is that important to be seen by you, or is it after 2, or is tonsillectomy a recommendation for anyone with an abscess?
So tonsillectomy is a recommendation for kids who aren't getting better. If a child has a peritonsillar abscess and is responsive to antibiotics, that's great, but it needs to be followed closely, because they tend to want to recur about 3 weeks later or 4 weeks later. So they had a horrible left-sided throat pain. They couldn't open their mouth that much because the pus that was sitting there is causing spasm of the muscles that close the jaw. They're treated with antibiotics. 2 days later, they're feeling a little bit better. A week later, they're doing great. They still need to be watched. And if that swelling starts to come back, then it's probably an indication for a tonsillectomy, because that abscess probably never went away.
Okay, that makes sense. Anything else you want to say about strep throat?
I think that we have guidelines for a lot of things, for strep throat, for otitis media or ear infections, but it really has to be a kind of a team approach, discussing with a team of the pediatrician, the otolaryngologist, the ENT doctor, and the parent. Not to say that one person has jurisdiction and another person doesn't have jurisdiction, but in order to get a complete picture of what is going on and how badly is it affecting the child, we need everybody's input. And so I think that kind of collaborative effort goes a long way, not will, but goes a long way towards making sure that kids get the appropriate care that they need.
Great. And what the earliest that you will see that you possibly see strep throat in children is what, like 4 or 5 as the earliest, or are we talking about 7? Because people come in all the time worried that their kid has strep throat, and I tell them they're not going to get it at young ages.
You can get it at an earlier age, and if there's a question, you can do a culture. And from my point of view, I'm always much happier to see a child and say, you know what, everything's great, you don't need me, than to hear about a child and say, wow, wish I could have helped. So I'm much happier with that.
Yeah. So if they have the constellation of symptoms that comprise strep throat at any age, it's worth treating and swabbing.
Yeah.
Okay. All right. So our last topic, are you okay on time?
Yeah. Yeah.
Okay. we've touched on this briefly. When and why should parents consider a tonsillectomy? So we talked about strep throat. Would you like to discuss some of the other reasons or talk more in depth
Sure.
about?
The other big reason is when the tonsils are so big that they're obstructing the airway. And a normal when a child, when they come in, parents say the child snores a lot. And so I ask a couple of questions. And for those people who will view this, I say, do they snore like this? Or do they snore like this? And usually, if it's significant, it's going to be the second. That's pulling to breathe. And I only do that for one breath because it's too difficult for me to do it 2 breaths in a row. So, and usually, oftentimes, it's a combination. I also, ask if they hear like a snore, then a pause, and then a big snore. The kid almost wakes himself or herself up, and that's basically a short apneic episode. And the last and very important piece is I ask the parents, when you watch your child breathing, are you concerned? Because if a parent comes to me and says, look, doc, my kid's snoring, it's very concerning to me. They know that I'm an ears, nose, and throat doctor. They know that I take out tonsils. They don't want their kid to have surgery. But if they're coming to me, they're concerned enough, and that makes me, perk up my ears and listen and say, okay, I may not see what I'm expecting to see when I look in the mouth, but I'm certainly going to give the parent's story credence. So sometimes I look in and it's big tonsils. So if a mom comes in and says, my child snores all the time, even when I wake, and I say, you mean like doing the Darth Vader thing? And they say, yeah. Especially when they're when they're engrossed in some activity. And I look in and they say mouth breathing all the time, snoring severely, pulling to breathe, short apnea episodes. And I look and I see tonsils as big as golf balls. Then I know that, that's a pretty quick one. Well, I have my assistant here. I have my 2 assistants here.
Oh, hey guys. They have any apnea?
Guys. So I have my those kids need to be they probably need to have their tonsils out. If the tonsils aren't that big, then we have to look and see, is it the adenoids? Get an x-ray and see. Is it some other thing going on that we need to, about which we need to follow up? People come in and they say, my kid's tonsils are huge. They need to get them out. And a lot of times they're right. And I listen to that. And sometimes I say, you know what, maybe we don't need to. Maybe there's something else that we can do. If it's only been for a couple of weeks, maybe they're acutely inflamed and we can treat with antibiotics. And even though they don't have the full signs of a strep infection or tonsillitis, but if we treat it and the tonsils get smaller and we avoid surgery, that's a win.
Yeah. The obstructive sleep pattern in children I see in my office with some pretty tired kiddos, but they have some ADHD-like behaviors. And I always tell parents to check in several times in the night and see if their mouth is wide open and how they're breathing. And that tends to lead to the first appreciation of what's really going on.
And that's a great idea. And I sometimes parents, I'll say, well, does he snore? And they're like, well, I'm not really sure. And so I'll say, if I see there's congestion in the nose, maybe some allergy history, I'll treat that. But I'll give the parents an assignment and say, your assignment is to, middle of the night, go in and check on your child and see what is the breathing like. And I want you to come and tell me that you're either comfortable with the way your child's breathing or not, because you're better than any sleep study is a mom or dad watching their child sleep.
Yeah, I have not had good success with the sleep studies. At least I don't get great feedback. And adults will tell you the same. Children, it seems to be even worse. But yeah. I will say, yeah, the education piece is important, that parents understand the long-term effects of the gases released in the endothelium of the bloodstream and hypertension later in life with chronic oxygen deprivation at night. And that's why there's this override where the mouth opens, because they're just not getting enough oxygen.
Right. The generally what drives our breathing is not a lack of oxygen. It's carbon dioxide being built up. And when a child, or an adult for that matter, is not breathing, that oxygen level goes down. And in an adult, to have sleep apnea, you have it's more than five or more times an hour that you either stop breathing or have difficulty, like the kind of thing that I did before. That's called the apnea-hypopnea index, or AHI. And in a child, an AHI over 1 is abnormal. And it's been shown that when a child has 1 episode per hour of the apnea or hypopnea, there can be up to 8 or 9 times in that hour that the amount of oxygen in the blood drops. So it's not something that we want to ignore, and it is something that needs to be watched and treated if necessary.
Do you have a recommendation for sleep studies? I know that there's a lab at Chalk. Does Memorial Care have any? And do you want to maybe mention
I think does, but I use sleep studies when things don't add up. If a mom comes in and says, my kid snores, mouth breathes, is tired all day, difficult to wake up, and I look in and the tonsils are huge, then I don't need a sleep study. Because if the sleep study is normal, I'm still not going to believe it. I'm going to believe the mom. If a kid comes in with a big, with small tonsils, but a very stuffed nose, pale purple, consistent with allergies, I'm going to treat that and get an x-ray of the adenoids and see if those are enlarged, and see him back in 4 weeks and see how the child is doing. If the kid is doing better and the nose looks better, great. If the kid is not doing any better and the nose looks just as congested, or the adenoids are large on x-ray, then I don't need to get a sleep study. I've got the reason most likely right there. And so it's only when everything looks good, and I'm not doubting the parents. I'm just trying to figure out what's going on and what is the magnitude of this sleep apnea issue. That's when I'll get a sleep study.
Well, this has been tremendous for me as a pediatrician, and I think I'll be sharing it with a handful of patients that have come in with ENT questions to the office. You're able to share it too through YouTube. I'm so glad that I got an hour of your time today. Is there anything you want to add before we close?
Nope, just wanted to thank you for the opportunity. It's always great to be able to give a little bit of information because as I said, it's a team approach, and when the parents, the more education they have, the better I'm able to speak with them and have a real collaborative effort. So thank you for this opportunity.
Well, I have a number of questions for maybe another episode. I'll give you a break, and I'll probably hit you up in a few months. Thank you so much.
Thank you.
Great rest of your afternoon.
You too.
Bye-bye.